Okay, so I think we probably will get started if that's okay. I know that there are going to be a few people joining. Most of you all know who Louise Newton is because she's been prolific in the amount of educational material and the huge effort she has gone to provide some education around HRT, prescribing remotely, and also just the menopause in general. And we've been really privileged to be working with her over the last 6 months. So my name is Mark Coombe. I'm a working GP, but I'm the director of education for 14 Fish. And I've been particularly interested in remote consulting because I was the deputy lead of the team that set up the remote consulting licensing exam for the Royal College over the summer. Just for those of you who don't Zoom very often, and sadly that seems to be quite a big part of most of our lives now, is please, if you could stay on mute. If you want to ask questions as we go along, please use the Q&A function, which go down to your bottom of your screen. You'll see a little icon there and you can put some questions. I'll keep an eye on that as we go along. There's bound to be some common themes, and I think probably give Louise a chance to go through her presentation, and then we'll do question and answers at the end. I did say that we'll try and keep to time, which is always the chairman's remit, but Louise told me to bugger off. And so for those of you who want to sneak away and watch Bake Off, then please feel free. But for those of you who want to stay on and ask questions, that's great as well. Don't forget, we have an ongoing confidence in the menopause community on the 14 Fish education site. So anything that isn't answered today or you want to follow up, do please go to the to that community on 14 Fish. Anyway, it's a real treat to have Louise here tonight. I was about to say in my house, but it feels like she's in my house, and actually she's not. So welcome, Louise, and we're really looking forward to what you've got to say.
Oh, thanks, Mark. So for those of you who don't know me, I'm a GP and menopause specialist, but I seem to have dedicated my whole life, much to my family's annoyance, to the menopause. So we decided to do this just because a lot of clinics sadly have closed due to COVID, or they've halted NHS menopause clinics. So most of you, if you are working in general practice, whether you're GPs or nurses or nurse prescribers, then you will be encountering menopausal women. So I thought this hopefully will be useful. So I thought I'd start with a scenario, because it's always good to think about work in the evening. So I'm going to present a case. So she was your last appointment on a Friday afternoon. It's always that Friday afternoon feeling that you have, and the receptionist didn't really know why she was coming to have a remote consultation, because she couldn't get much out of the poor patient, because she was very tearful when she phoned up demanding an appointment. So this lady, Mrs. Amy Smith, her name is made up, but she is actually a real case. So she's a 48-year-old accountant, and she comes and she's telling me she's having night sweats, she's being very tired, and she just generally feels awful. Something's happened, she said, and my body is not the same, and I'm really worried because I'm so tired and I wake up with these sweats. So you're thinking, right, you've just done some hospital medicine. Has she got a lymphoma? Has she got another cancer? What else is going on? You look at her notes, and she's had quite a few blood tests already by the time you see her, and all her blood tests are normal. She's actually recently had an ESR, CRP, full blood count, usual bloods, all normal. So you're thinking, right, I better ask a few more questions. So you carry on asking her what else is going on. And she's got a history of migraines, and she says they're worse. They've become really severe. They're really impacting on the ability for her to function. And she's tried various heavy-duty medications. So she's been on pregabalin, dipyramate, gabapentin. None of them have helped, and actually, unsurprisingly, a lot of them have led to really awful side effects. She tells you she is more tired, and she has far less energy and stamina than she used to have. And she's quite forgetful, and as an accountant, it's really affecting her ability at work. And it's quite frustrating at home, because she's forgetting things that her children are telling her, forgetting sometimes their games kit to take to school. She's also noticed she's been a bit clumsy at times. She sort of walked into to cupboards, got a few more bruises down her legs. And her concentration just isn't there. She's just not so interested in things, finding it hard to remember. So then you're thinking, right, has she got some intracranial pathology? Maybe she's got a cerebral lymphoma. You look at her notes, and actually, she's come so many times with migraine. She's been seen in the specialist migraine clinic. MRI of her brain was normal. So you're thinking, right, what else? She tells you she's got joint pains, muscle stiffness. She can't run like she used to. Very poor stamina. So then you're thinking, well, she got an arthritis, has she got fibromyalgia, she got chronic fatigue. All these things are going on in your mind. But again, you're looking at her notes. She's been over-investigated. She's had a CT of her hip, which was normal. You know her bloods are normal. She had X-rays. She's had X-rays as well, which have been normal. So you keep going with your history. She's had very little motivation, but she also tells you her self-esteem is low. She's not going out with her friends. Her mood is low. She's more tearful. She tells you she's just generally feeling flat. She's not enjoying life anymore. Her sleep is poor because she's getting these night sweats, but even when she doesn't have night sweats, she describes early morning wakening. She's often waking at 3, 4 in the morning, lying there, unable to get back to sleep. Her libido is low as well. So now you're thinking, right, she's got to be depressed. She's got a lot of symptoms to suggest depression. But you're looking at her notes to help you, and they're not really helping you here because she's already had 3 different antidepressants. And when you ask her, none of them have helped. She'd even tried some CBT that she got privately through work, and that didn't help either. So you're really scratching your head. So you ask her a few more things, increasing frequency of micturition. She's getting up in the night, but also during the day as well. She's also got some localized soreness and dryness. And she says even wearing underwear is getting quite uncomfortable for her. So you're thinking, well, she's probably had recurrent UTIs, maybe thrush. But she's had 5 negative MSUs. She's had an ultrasound of her renal tract, which is normal, and 3 negative swabs. You look at cervical screening, the recent one, she couldn't actually proceed. It was so painful, but no one actually gave her any treatment. She's also very irritable, argumentative, and these are recent onset symptoms. So now you're thinking, right, maybe she's got some PMS. You're thinking more about the hormones. So there's no mention of PMS in her notes, but she has had postnatal depression. And as some of you know, people who've had most postnatal depression quite often have PMS. So you think, right, I'm going to ask her the really obvious question. What about your symptoms? Do they change with your periods? But then she tells you her periods have stopped 18 months ago. So you've got it, you've cracked it, you know what's going on. But she says, no, I know I'm menopausal. I've had medication already. And she brings pictures. And I'm not joking here. This is one of a patient I saw in my clinic who had given, this lady had actually been given 5 different antidepressants in the past by her GP. She knew she wasn't depressed. So she'd bought all these different preparations out of from the internet because she was housebound. She was crippled with anxiety, this lady. And I'm not joking when I tell you she had tried all these preparations. So then you're thinking, well, this poor lady. So she said, yes, I went on to NHS Net because I wanted to get some treatment and I Googled menopause. So I went on, but then it said, find out about hormone replacement therapy, how it can help symptoms, the different types of HRT, what the main risks and side effects are, including how it can raise your risk of breast cancer. She said, and then the article talks about blood clots, breast cancer. She just said, there's no way I'm taking HRT, doctor, but I don't know what else to take. So you're thinking, right, how the hell am I going to help her? She's taken already 7 or 8 minutes of your 10-minute consultation, and it's Friday afternoon. But this woman's desperate. Her life is really affected. She's really struggling at work and at home. So you think, right, the BNF might help me. You open it, and it's talking about cancers, and it's talking about clot and stroke. Well, this is someone who's got migraine as well. You're a bit worried. So you think, well, this maybe is out of date because it's talking about a study in 2002. So you look online, breast cancer is mentioned again, and you're just thinking, do you know what? She's worried. I'm worried now. What do you do? So then you remember there was a letter that came from the MHRA last year following a study. You never had time to read that study because you're so busy. So this is a letter. It came from the MHRA. This is important because this is from the Department of Health. And then there was a letter to GPs, to patients taking HRT. So you try and find that as well. And it's talking about breast cancer. And it's talking about shortest time, lowest dose of HRT. Breast cancer is mentioned again, risk. You're not noticing anything good about HRT here, so you're really, really struggling. But then you also remember the last time you tried to prescribe HRT, you had lots of warnings. All these things came up for estrogel. It talked about clot, it talked about heart disease, all these contraindications. And now you're thinking you're going to feel a real muppet in front of this patient. I'm just not brave enough to prescribe HRT. So what are you going to do? And I think that's probably how many of us would feel. And I'm hoping by the end of this, you won't be feeling like that. So let's take a step back. You've done this, you've listened to this presentation, you feel more inspired. And so what will happen again when Amy makes an appointment? She still wants that Friday afternoon appointment, but this time, your receptionist, you've done some training, you've helped your staff to understand about the menopause. She again phones up very tearful. Your receptionist notes her date of birth, so she's 48 years old. So then she's already thinking maybe. So she says in a very open way, do you think any of your symptoms may be due to your hormones? To which Amy says, well, I don't think I have hormones because my periods have stopped. So she said, well, maybe it's an idea. I don't know if it is, but maybe you could just read up about the menopause. Do you know anything about it? She tells her about the book that I've written. She refers her to some booklets. She gives her a myth sheet, tells her to go to the website. Some of you know I run this website, menopausedoctor.co.uk, which has evidence-based information. It's completely unbiased. I'm not sponsored by anyone. I don't work with pharma. So she says, while you're waiting for your appointment to come through at the end of the week, just go and read. She also says, download the app. This is a free app that I have created with a great team of people, which is available for anyone to freely download. And she also gives her a menopause symptom questionnaire and says, fill this out and bring it to your appointment or email it to us so the doctor can see it for the consultation. So this is Amy. You can see she's got extremely ticked in many of the columns. But actually, Amy's a bit more savvy. She downloads the Balance app and there's a health report. So it can put in her cycle, but it also can put in her score. And you'll see here, she's put it in July and November, and things have got a bit worse. And this gets emailed to the GP in advance. So you've got this information. So you're only 1 minute into your consultation, and then you're thinking about HRT. So hopefully, even those very savvy measures have made quite a difference to your Friday afternoon. So I'm going to come back to Amy at the end. I just want to reflect. I know there's people listening today. Some of you will be very experienced in menopause and HRT prescribing. Some of you might be a bit scared. So I'm just going to take it a step back if that's okay. The menopause affects all women, and this slide was kindly given by Dr. Nijat Arif, and these are all menopausal women. The menopause doesn't select certain types of women. We will all go through the menopause if we live long enough. As you know, in the UK, the average age is 51, not that any woman is average, but 1 in 100 women have an early menopause, premature ovarian insufficiency. So we have to think about young women, 1 in 1,000 under the age of 30. But the reason it's so important is that our life expectancy is far more than it was in the Victorian times. The average age of death in the UK for women is 82. So that means about 1/3 of our lives are postmenopausal. So we have to really shift the perception of the menopause and think of it as a long-term female hormone deficiency. It's not just a group of symptoms that we might or might not experience, or we might get through the other side. I saw someone in my clinic yesterday who's 38, well, actually that's a lie, she's now 58. But when she was 38, she had an early menopause, and her doctor had done her blood test and said, your blood test is very high, your FSH level is incredibly high, you're through the menopause now. No one's ever through it. You're always going to have low hormones unless they're replaced, because we don't make any more once our ovaries have stopped working. So this is just to remind us that estrogen works all over our body, and I cannot think of any cell that does not have an estrogen receptor on it. And if anyone thinks of one, please put it in the Q&A. So if you think about how important estrogen is to every cell in our body, then you soon realize how many symptoms can occur. My youngest patient in my clinic is actually 19. She had a rhabdomyosarcoma when she was 14 and only had 2 periods, and then they stopped because of her aggressive chemo and radiotherapy. She had lost a lot of weight because of dry mouth, and she couldn't eat. So, dry eyes, dry skin, dry mouth, even muscle joint pains, a lot of the symptoms that Amy was describing are very classic menopausal symptoms. So this is a pictogram that we had produced with West Midlands Police when I did some work. And I think it's a great picture because it shows so many different symptoms, and we had it put on the back of all toilet doors. But one lady actually said to me, do you know what, every time I go to the toilet, I just look at that lady, that menopause lady, and that's me, but I have nowhere to go to get help, so I feel sad. And this is awful. We have to be recognizing all these symptoms, and any healthcare professional that sees a woman, an adult woman, as part of their work needs to know about the menopause. So how do we make the diagnosis? This is a remote consultation. We can't do any investigations easily, but do you need to? The menopause is not a biochemical diagnosis, it's a clinical diagnosis. So we've got the questionnaire. Amy's told us her last menstrual period was 18 months ago. So by definition, it's very easy to diagnose her. You don't need a blood test to confirm or refute it. But actually, even in the perimenopause, so the time before the menopause when the hormones start changing, it's very difficult sometimes to know. FSH levels can be very misleading. And these are just some results that I plotted on a lady I saw a while ago in my clinic. And her doctor had thought she maybe had POI. This lady was 39, and you'll see right on the left, she had raised FSH, but she saw 3 different doctors who said, no, you're too young, it won't be your hormones. And then about a year later, she went back to a different doctor who did some FSH levels and said, no, they're normal, so it can't be your hormones. And then again, a few months later, her FSH was raised. And no hormone stays the same. It's very fluid and dynamic. So if they're raised, it can be helpful. But if it's normal and the lady's sitting in front of you with all these symptoms, you have to think about hormones. So NICE guidance tell us if a woman's under 45, then FSH level might be useful. If they're under 40, you should be doing it. But actually in practice, I see a lot of young women, and it's very obvious by their history. So it would be cruel of me to say to them they have to have blood tests and I can't give them any treatment. And if someone's had a nephrectomy, you don't need to do a blood test, whatever age they are. We sometimes do estradiol, testosterone, SHBG levels, and I'll talk about those a bit later. If you think something else is going on, then thyroid function test, ferritin. A lot of women we see are perimenopausal with very, very heavy periods that no one's addressed at all. And we often do ferritin levels because it's important and their full blood count. So, we're a lot of us work in primary care, GPs, nurses, so you know what bloods you should do. There's nothing that you have to do really, and certainly not on this Friday afternoon that's going to make any difference to your change in management for this lady. I'm just mentioning contraception. This lady is 48. She's 18 months since her last period. So for the next 6 months, she needs to think about contraception, really. I have done a module, which is a free module through 14 Fish, contraception in women over 40 years. So I'm not going to talk about contraception again tonight. So as some of you know, I'm a physician. I've got MRCP as well. I've done a lot of hospital medicine. So I'm not so interested about gynecology. I'm very interested in disease prevention. And with the long-term hormone deficiency that occurs with menopause, there are real health risks. And this is why it's so important, because we're living so much longer. So we have to think about this rapid bone turnover and bone loss that occurs without estrogen. 1 in 2 postmenopausal women will become osteoporotic over the age of 50. And I'm sure you've all seen similar ladies to this one in the wheelchair. Breathing's difficult, digestion's difficult, mobility's difficult, multiple fractures in her spine, often on morphine, causing constipation, really difficult. And we know, 1 in 2 women will develop an osteoporotic hip fracture, costing £2 billion a year to the NHS. Osteoporosis will never get to the front page of the Daily Mail like breast cancer does, but it's really, really important. And it's a very expensive disease, both in financial costs, but personal costs as well to the patients. Women going through the menopause, more likely, 5 times more likely to have a myocardial infarction and more likely to die after an MI compared to men. Type 2 diabetes on the increase anyway, but increase more because of the metabolic changes that occur without estrogen. We know that obesity is increasing worldwide. We're one of the fattest countries. And women do put on weight. It's not because they are eating more. Some of them obviously do comfort eat. They get sugar cravings because of their low estrogen. But the metabolic changes that occur result in weight gain, especially around the midline, because the body's trying to conserve fat cells, which will make a really weak, bit pathetic really, estrogen, but it's all it has. So a lot of women find that they put on weight. We know that dementia is far more common in women, and that's not just because women are living longer, it's because of the hormone estrogen and testosterone, very important for the way our brains function as women. And depression. We know women going through the menopause are more likely to have the low mood symptoms that I've already discussed, but they're more likely to have clinical depression as well without estrogen in their body. So the menopause has to be an opportunity. It's not a doom and gloom menopausal woman, she's just a bit of a whinger. It's actually, we can really transform her future health if we look after them properly in this consultation. So it's your key chance. You've got 10 minutes to really transform Amy's life, because she's not going to come back again. She's been back and forth to the doctors. Loads of money's been spent on her, loads of time wasted on appointments. But you, in that 10 minutes, can really make a difference. We've got guidelines. Guidelines are there for us to adhere to. We might not agree with all of them, but actually it's pretty hard to stand up in court and say, I'm sorry, I've ignored the NICE guidelines. NICE guidance in menopause came out in 2015. They're quite easy to read. There's a good summary, but we should be looking at them and we should be adhering to them. And if we don't, we need to be able to justify why we're not. So the summary of them basically is we should give women individualised care. Well, we should do that with anything we do, whether it's diabetes, hypertension, heart failure. We need to individualise our care. It's really important that young women with POI and early menopause have to have hormones to replace their missing hormones, unless there's really a good medical reason not to. Because without that, these women have even longer without their hormones, and they're far more likely to have these diseases I've mentioned. So it's key that these women have replacement. We see so many women in our clinic who've had an early menopause, a surgical menopause, maybe in their 30s or 40s, and no one's given them HRT. So for the majority of women, the benefits of HRT outweigh any risks. And this is really important. You know, when I showed you those slides at the beginning from the MHRA, from the BNF, it's all about risks, risks, risks. We have to think about the benefits. There are benefits. There's also no maximum length of time. You wouldn't stop someone's thyroxine when they reach the age of 70. You wouldn't stop someone's insulin when they reach the age of 80. Why would you stop someone's estrogen because they've gone to a certain age or they've had it for a certain length of time? It doesn't make sense. We have to think about holistic healthcare, not just with menopause, but with everything. So lifestyle is very important. What's really shocking and saddens me is that it's very hard actually to get good quality menopause care. Some of you might know I run a practice, a menopause clinic in Stratford-upon-Avon, and it's private. And it's private because I can't get a job in the NHS as a menopause specialist. I have tried, but there's no funding for one. So we have a clinic and we have lots of doctors that work with us, but we still have thousands of women on a waiting list actually. And all of these women have been refused HRT for the wrong reasons. And we know the minority of women take HRT, about 12-14% in the UK, and I've already said the benefits outweigh the risks. So lifestyle, I'm not going to go through it. We should do this with all our patients, but we should ask menopausal women, and we recently did a survey of 3,000 women, and only 24% had ever been asked any lifestyle questions. That takes a minute. You know, do you drink, do you smoke, do you exercise? That should be done with Amy. So why are so few women taking it? You know the answer. Everyone's worried. The media have been given wrong information. Women have been given wrong information. Us as healthcare professionals have been given wrong information as well. So it's a lot easier to prescribe an antidepressant than it is to prescribe HRT. So how to prescribe it? Do you know what? My brain is keeps things very simple. And HRT prescribing can be done very easily, and I hope I can show you. So obviously the most important hormone for women is estrogen. So any type of HRT will contain estrogen. It comes as a pill, a patch or gel, and now there's a spray as well actually. So I put the patch and gel in bold because that's what I tend to prescribe, and I'll explain more in a minute. And then if women have still got their womb, then they need to have a progesterone. So they have their estrogen, and then they have usually micronized progesterone or Mirena coil. This is body identical HRT. And testosterone as well, which I'll mention in a bit. So keeping it really simple. There is an easy HRT prescribing guide that I've written, which is available on my website. If you go to menopausedoctor.co.uk and search easy, it will come up. And actually, the Royal College of GP have approved its use, and it will just go through some more information with evidence in it. This is an article I wrote for the British Journal of General Practice, and just really talking about the effectiveness for transdermal estrogen and the natural micronized progesterone for menopause and perimenopause. So if any of you want to, that's just got some more information, just exploring the evidence. And this really is the optimal HRT for the majority of women. If you look at estrogen through the skin, it comes, as I've said, patches, gel, spray. The spray is more recent. This is called Lenzetto, and it's a similar cost. In fact, the pharmacist yesterday told me it's slightly cheaper to the NHS than some of the other preparations. The advantage of having it through the skin is it goes straight into the bloodstream. So it bypasses the liver, which produces our clotting factors. So there's no risk of clot or stroke. Oral estrogen has to be metabolized. It gets broken down. The liver clotting factors become activated. Also, it doesn't matter what you eat, what your digestion is like if you have it through the skin. And you can change the dose a lot easier as well. So this means women who have a personal history of a clot, a family history of a clot, can still safely use transdermal estrogen. It also, I've written here, doesn't affect the sex hormone binding globulin. Now, our sex hormone binding globulin binds testosterone. So if we have oral estrogen, it increases our sex hormone binding globulin. So it means we've got less freely available testosterone to work. So it will lower an already low libido. So it's just a lot better to have transdermal estrogen, which doesn't affect the sex hormone binding globulin. Nice, so we can consider it if women are obese, also women with diabetes, migraine, gallbladder or liver problems should use it as well. And whether they have migraine with aura or not, I still think it's better to use transdermal estrogen. And I've put here in red, it should be considered first line. If people look about the cost isn't actually much different. And NICE do say if you take into consideration the cost of investigating or managing women with VTE following oral estrogen, then it is quite a cost neutral exercise actually. So I think I have 2 or 3 women who have oral estrogen. One of them is because she wants to, she's just used to it and she's got no real risks for a clot, and the other 2 just finding it very difficult to absorb the estrogen transdermally, so we've given them some oral estrogen. Most women I usually start and I give them the choice, whichever they prefer to use. So the 17-beta estradiol, sorry, I've missed the L there, is body identical and it's derived from yams, the root vegetable. And that's really important. I tell a lot of my patients that because they all think it's made of horse's urine, pregnant horse's urine, and it's not. And it comes as a patch, a gel or a spray. And I've listed the common ones there that we use. So I tend to use Everol, which is it's a bigger patch, but it sticks on really well. And there are 4 different doses. Estradot is smaller, it's a bit more like a postage stamp. And some people find that sticks on well. So it depends on the glue and the skin type. Elest is quite good as well, 40-80 they do. I'm not quite sure why it's a different dose. Some people find the 80 is as good as the 100 when you compare. And then we've got the estrogen gel, the pump, and then Sandrina, which comes as sachets, which is good for some people, but it's a bit of a faff because it's a little sachet you have to tear every day. It can be good for traveling. And then we've got the Lenzetto spray, which is just a spray that goes on the forearm, which has come out recently. Now, these are the recommended doses, and the maximum licensed dose is 100 micrograms or 4 pumps of gel. Now, we often use higher doses, especially in younger women, but even in women such as Amy in her 40s might need a higher dose if she's still getting vasomotor symptoms. Sometimes we top up with the gel. So, for example, if someone's using a patch, but they're telling us they're perimenopausal and every sort of third or fourth week for a few days they're feeling worse, they're getting some night sweats coming back. Well, those people just having their own endogenous hormone production as well, which is reducing around the time of their period, I often say to them, well, just use a pump of gel around that time just to top up. Because it shouldn't really be called hormone replacement. You're not replacing perimenopausal women's hormones, you're topping up. So once you think about that, even women who are quite early in their perimenopause, who've got just a bit of PMS, you could just give them a little bit of gel just for those few days before their periods, and you will transform their lives. There's a whole debate as to should we give them more progesterone if we increase their estrogen dose, and the IMS have recently produced a consensus statement for women with POI, and they're saying that you should. We talk about it a lot in our practice, and we do quite a lot of estradiol levels to check the absorption. And we actually, as a group, have decided that we don't need to. If a woman is not having any breakthrough bleeding, even if she's on, for example, 100 microgram patches, she doesn't have to have any more progesterone, because the progesterone that she's having is protecting her endometrium because she's not bleeding. And that's debatable, but if her level of estrogen that's in her skin, her estradiol blood test isn't ridiculously high, she's controlled in symptoms, she's not having any bleeding, then I'm quite happy that the progesterone is doing its job. So the patches, for those of you that don't know, they're usually applied to obviously clean, dry, hair-bearing skin below the waist. So usually on the bottom or lower back. There are some women, especially women who wear jeans a lot, maybe quite overweight or obese, find that it just doesn't stick or it crinkles a lot. So sometimes people put it on their shoulders, and you know, there's no reason, there's no difference to the skin above and below our waist. The gel is licensed to be on the upper outer arms or the inside of the thighs, but again, it could be rubbed in, and it's the instructions actually saying not to rub it in, and I'm not sure why. So I always recommend to rub it in like a moisturizer. But there are some women that find it just floats off their skin, and if it does, then it's worth just checking, because if she's not feeling better, it might not be because she needs a higher dose, it might be she needs to change to the patch because she's not absorbing it. Or some people find the Sandrina is better, slightly more concentrated, so less volume than the estrogel. And then the spray that's recently come out is a very fine mist, and it can go on the inside of the lower arm and the inner forearm, and you can actually put 3 sprays on one arm. So there's a lot less volume. So for people that need higher doses, it's a good alternative. The doses equivalents I won't go through because they are available on my website. There's I've just put the title here, so if you search ingredients or brands or strengths, it will come up with an article that you can download and print off. So I've thought of all the different preparations, the oral and the transdermal, and compared them. They're only a rough guide, however. So the manufacturers, for example, of the Lenzetto spray say that one pump or one spray is similar to 2 pumps of the estrogen gel, but in practice we find that you need to use more, and it's pretty much similar. 1 pump of estrogen is similar, the efficacy is similar to 1 spray, so that's why you'll think that this might be inaccurate what I've written, but this is how we see in practice. So I've already said the type of progesterone matters. So progesterone is needed for women who still have their womb, women who have severe endometriosis, and maybe they've had a hysterectomy, but their surgeon can't guarantee that all their endometriosis has been removed, then they sometimes still need progesterone as well. So hopefully you've all heard of the micronized, this body identical progesterone. I've already said it's derived from the yams, so the estrogen's derived from yams, the progesterone's derived from yams, the testosterone is. I hope there's somewhere in the world that makes a lot of yams. So if you look at the data about the risks of HRT, I'll talk about breast cancer in a minute, but if you think about the risks of the progestogens, the progestogen just means a synthetic progesterone. So all the studies, the ones that get regurgitated all the time into the journals, but also the older studies with the WHI, are all synthetic progestogens. And it's really important to know the difference, because progestogens are not nice. I don't know why they're even used for contraception, really, if you think about it. They can They can increase lipids, they can increase cardiovascular disease risk, but they also can increase VTE risk as well. So it's not just the oral estrogen that's the bad guy, if you like, it's the synthetic progestogens as well. So the micronized progesterone, actually, there's been some work that shows it can improve cardiovascular risk and also improve lipids. And we know that estrogen lowers lipids as well. It also, which is important to know, has a neutral effect on blood pressure and may actually lower blood pressure. It has no VTE risk. So you wouldn't want an oral estrogen in someone that's had VTE. You also wouldn't want to use a synthetic progestogen on women that have had a clot as well in the past. When you look at the whole breast cancer risks, there's not been a randomized controlled placebo study, but a good review has shown that there's no increased risk of breast cancer if micronized progesterone is taken for 5 years. And that's really reassuring, especially for those women that are starting HRT. You can say to them, look, you can just start it, try it, and you know that you haven't got an increased risk of breast cancer. It's also very well tolerated. It's got less side effects. Problem is, if any of you are listening from Scotland, it's not widely available, which is absolutely outrageous because this was a costly when it first came out. It was more expensive, and it's not expensive now, and it really needs to be challenged because it should be available to all women. So I've already said Utrogestan is the progesterone. It's the only one in the UK. It's called Progesterone 100 milligrams. Now there is a 200 milligram pessary that's used for some fertility treatments. It's not that. It's a 100 milligram capsule. And there's 2 ways of prescribing it. So again, I just want to make it really easy. Give the estrogen patch, gel or spray. Change the dose according to the needs of the patient. And then if they've got a womb and they need a progestogen, give them Utrogestan first line. Now, continuous, it's licensed for 25 out of 28 days. Goodness only knows why they said that. There's not much real evidence to support that. Generally, we just say take one every night. No one wants to count days, and these women don't want their periods back. Or you can give it cyclically. So there's always different things. I read so many ridiculous things, actually, about when to change from cyclical to continuous. So again, to keep it simple, as a rule of thumb, if a woman is still having their periods or her periods stopped within 12 months, then I would try her cyclically first. And then it's licensed, again, it's a bit ridiculous, they say for 12 out of 28 days. No one wants to count days, so we just say 2 out of 4 weeks. So for 2 out of 4 weeks, they take 2 at night. And then the other 2 weeks, they're not taking anything. And then they can carry on like that for 6 to 12 months and then convert them to continuous. They don't have to do it at a certain age. It's a lot better for the endometrium to have continuous HRT, so continuous progesterone. So even, for example, if they're 28, you don't want to wait till they're 51 before changing to continuous. Just get them onto a pattern. It's a lot easier when they're not perimenopausal, so when their own endogenous hormones have reduced, and then you can put them on continuous. If they get a lot of breakthrough bleeding when it's on continuous, I always warn that it might happen for the first 3 months or so when you change from cyclical to continuous. But if it persists, then they can just go back to the cyclical way of taking it for another 6 months or so and then try again. But it is better for the lining of the womb to have continuous HRT. So 1 at night, it's taken at night because it can be a sedative, which is quite a nice side effect for a lot of women, or 2 for 2 out of 4 weeks. So very easy to remember. Now, they say take it on an empty stomach, and that's because if a woman's eaten, it can increase the absorption. But actually, progesterone is very safe. It has a slight estrogenic effect on the bones, so it's good for bones. It's not really dangerous. So if a woman is doing shift work, for example, and comes in, eats a meal, wants to go straight to sleep, she doesn't have to wait. It's fine. She can still have it. Now, some people have progesterone intolerance and they find that they get side effects with even the natural progesterone. So it can be used off license. It's half the dose vaginally, and I've put in the reference there for any of you that want to look it up. So this study has shown that 45 milligrams a night is enough to provide endometrial protection if it's used vaginally. Now, we haven't got 45 milligrams. We haven't even got 50 milligrams, but we've got the 100 milligram, and it's a sort of gel-filled capsule. So they can just insert that vaginally. they can just, you have to just explain to them it's the same oral capsule that they're going to use vaginally, and they use it alternate nights if they want a continuous preparation, or cyclically they just insert one vaginally rather than take two orally, so it's half the dose, and they do that for 2 out of 4 weeks. Some women, if they want to use an applicator, now the 200 milligram Progesteron does come with an applicator that you can use the 100 capsule in, but don't use a 200 milligram vaginal preparation. Firstly, it's double the dose that you don't want, and secondly, that's a lot more expensive, so your local pharmacist won't be very happy with you. So just use the same one, but explain to them it's the same capsule that you can insert vaginally. The Mirena coil is obviously really good for women who are perimenopausal, those women that are having heavy bleeding, or women who just want an alternative. Obviously, it contains a synthetic progesterone, but it's a very low dose. And although it's only licensed for 4 years as endometrial protection, the Faculty of Sexual Reproductive Health have said we can use it for 5 years. And we have a lot of women that just have it replaced every 5 years, and it can work very well. So, and especially for young women, it can be really good if they want contraception. So there are alternatives for those people who want an oral treatment, or for those people that are listening to me and thinking, well, do you know what, I can't prescribe Testosterone. So we want a really good, nice progesterone. There aren't many, unfortunately, but Progesterone is the best one. We can get it by itself in Europe, but you can't in the UK. So it comes with Femiston, which I'm sure many of you have heard of. So there's Femiston 110 or 210, which contains 1 or 2 milligrams of estrogen if it's a sequential HRT. Or they've got a very low dose, which is really a baby dose, 0.5, with a lower dose of Progesterone. Or there's the 1.5, which is a continuous preparation. Now, 1.5 is still a low dose. So I do have some ladies who take that and then they top up with some gel to get more estrogen, because I wouldn't want to give them more oral estrogen if they can avoid it. But some women find that they much prefer that as a type of progesterone to take. There is the combination. Oh, there are the combination patches, Evrel Conti, Evrel Sequi, and they contain synthetic progesterone, and they can be useful. So certainly in Scotland, if you just want to bang someone on a patch, you haven't got Progesterone, they can have that. And the Conti is the continuous preparation, Sequi is the cyclical preparation. Just remember, they only contain 50 micrograms of estradiol, which is actually quite a low dose. So you might need to top it up. And rather than using 2 of those patches, I often would say use 1 of those and then use a 50 microgram patch just of Evrel, or maybe use 1 or 2 pumps of gel. Again, if they're not getting any bleeding, you know that the lining of their womb is protected, so you can be reassured about that. So the progesterones, the side effects to these are the big reason why people don't like HRT or stop taking it. And some studies have shown 10 to 20% of women have some progesterone side effects, and that's quite a lot actually. So it's always about trying to maximize the benefit and minimize any side effects. As I'm sure a lot of you know, bloating, fluid retention can be very common, and a lot of women think they're going to put on weight with HRT because their mother or their sister or their auntie did, and that's usually fluid retention. We know actually that women who use transdermal estrogen with micronized progesterone often lose weight because of the metabolic changes that occur, and often because their lifestyle improves because they're feeling better as well. So side effects are less likely with micronized progesterone, and micronized progesterone, as you know, is more selective for the progesterone receptors, and it has less interaction with the androgenic and the mineralocorticoid receptors that some of these synthetic progesterones do. So less likely to cause spots, less likely to cause fluid shifts, and I've already said less likely to raise your blood pressure as well. Some women feel they have a very low mood with progesterones. Even with the natural progesterone, they can feel very low, very flat. And breast tenderness. Everyone blames estrogen for everything in HRT. Estrogen is the really good part of HRT, but it's often the progesterone or the synthetic progesterone that can lead to breast tenderness. And quite a few patients that I've seen have found just using the Progesterone vaginally can reduce breast tenderness. It's often a short-term side effect as well. So I usually warn people that you might get breast tenderness for the first 3 to 6 months and it should settle down. Bleeding is a nightmare for a lot of women, and I think there is some more breakthrough bleeding with using micronized progesterone than there is with using synthetic progestogens, but I still think it's worth persevering because there are so many benefits with using micronized progesterone. Usually say to people, should settle after around 3 to 6 months, and the guidance say we should investigate if it persists beyond 6 months. And I take this a bit loosely, and this is because we have some women who you talk to are perimenopausal, and they tell you that they've had a bleed maybe at 7, 8 months. But just before that bleed, they were getting breast tenderness, they had some lower abdominal pain and bloating, maybe a bit of backache, like they used to have before they had their periods. And they know, and then they say, oh, I bled for 4 days and I haven't had anything since. Now, these women are really, really unlikely to have endometrial cancer. It's more likely due to their hormones. Obviously, if someone has bleeding after a year or 2, and certainly if it's persistent and fresh blood, absolutely investigate straight away, do a 2-week referral. But a lot of people, you can just take a really good history and then decide they don't need a 2-week referral, and they certainly don't need to stop their HRT while they're having their investigations, which is what a lot of women incorrectly are told. It's worth doing a scan on people that have bleeding, because I often pick up a polyp or a fibroid or something else, or adenomyosis. So I would definitely investigate them, but I wouldn't investigate them with that urgency unless they were having persistent, heavy red bleeding. So use your clinical judgment on that, really. So I put in a slide about POI, premature ovarian insufficiency. Now, it's not POF. People used to say primary ovarian failure. There's nothing failing about these women. Their ovaries are insufficient, sometimes because they've been removed, but often it's idiopathic. We don't know why it happens, but it's common. And these women often need higher doses of estrogen because you want to give them physiological estrogen. If women don't have enough estrogen, then they're still going to have these health risks, such as increased risk of heart disease, diabetes, osteoporosis, dementia. And it's more pertinent in younger women because their bodies need to have higher levels. So often what I would measure an estradiol level, and I'd like to keep it above 250, some women even a little bit higher if they're still getting symptoms. And there's a really good study that shows that women who have vasomotor symptoms when they're on HRT, even if they're mild, still more likely to have osteoporosis and heart disease. So those women that say, oh, I've gone from 20 flushes a day to 3, doctor, I'm fine, it's not enough. And it's a bit like when you treat hypertension, you don't bring it down to just borderline especially if they're young. You want it really well controlled, and think about that in the same way. So we have some people that use 2 patches, 2 100 microgram patches, some that have 3, very few, but we do have some, and they might be required for symptom control. And certainly when I was in my mid-40s and started HRT, I was recommended to use a 100 microgram patch, and a few months later I felt no different. I was really disappointed. I wanted to feel amazing like all these women have told me for years, and my consultant said to me, well, Louise, just use another patch. And I said, no, I can't, that's far too high. And he said, but your level is 110, it's low, you're telling me you're getting night sweats, so what are you worrying about? I said, I don't know, I've not really thought about it in that way. And we get a lot of letters from quite angry doctors telling us that we're going to give these women breast cancer because they're using such a high amount of estrogen. Well, firstly, these women are young, so they won't get breast cancer due to their HRT. Secondly, estrogen doesn't cause breast cancer, actually lower risk of breast cancer in the future. And thirdly, all we're doing is giving them back their natural hormones. So you just have to be a bit more confident. So I've put as a guide above 250, just look at physiological levels of estradiol, and actually just before ovulation they can go up to 1200-1300. So anything below 1000 you're still quite comfortable, and some women actually tell us that they feel better when their levels more like 600-800. But I don't obsessively do levels. It's more about do their menopause symptom questionnaire, see how they respond, see how they feel. That's more important than a number from a blood test. So I've already said, try and give them continuous progesterone unless they're wanting to get pregnant. So women with POI, they're not all infertile. Some of them can have reduced fertility. but can actually improve with giving them HRT because it almost relaxes their ovaries, so their ovaries might squirt out an egg. So give them cyclical progesterone then. And we've actually had 2 pregnancies in my clinic, which has freaked my receptionist when they phoned to say they were pregnant, but they were delighted. And these were young women who had been to fertility clinics, but no one had spoken to them about the menopause. So obviously, continuous progesterone or Mirena is better to be period-free and better for endometrial protection. Testosterone is often beneficial for younger women as well. There's very few women with POI that wouldn't benefit from testosterone, which I'll mention in a bit. So testosterone prescribing, I don't know how many of you listening have ever thought about testosterone or indeed prescribed it. And up until a few years ago, it's never been on my radar because I'd never been taught about it. We always get taught about estrogen and there's testosterone in men. But actually, women produce more testosterone than estrogen from their ovaries. It's quite staggering when you think about it, actually. If you look at the levels, estradiol is measured in picomoles and testosterone is measured in nanomoles. And so we just produce more, but we're not allowed it once we go through our menopause. And these poor young women aren't allowed it when they have an early menopause. And women that have their ovaries removed aren't allowed it back. But we go by the guidance. All the work I do is evidence-based. And so we have the nice guidelines that say we can consider testosterone in women with low sexual desire despite taking HRT. Now, a lot of the studies in testosterone have been about sexual function, libido, number of times having sex, and you can call me cynical, but I think a lot of these studies have been formulated and done by men, and you can gauge a woman by how often she has sex, and we're not sexual objects, and libido in women is a bit more complicated than just having a hormone, but it's often other reasons that people find benefits from taking testosterone, and it's a very important hormone in our brains. So a lot of women find their mood, their energy, their concentration, their emotional energy, if you like, their brain fog lifts, their just general enjoyment. Amy told you that she was feeling very flat, just like her joyless. Just someone said to me, my zest for life is gone. And often that's a testosterone thing. You can give all the estrogen you like, but you're not going to stimulate the testosterone receptors. So often it's the mood, energy, concentration that improve. We don't have a licensed preparation for women, which is quite outrageous and scandalous in my mind. So we have to use what we can. So there's on the NHS, the ones that I would recommend actually are Testim, which has recently come back on the market. It was off for a while, but apparently it's still available. And it comes in little tubes, or there's Tester Gel. Now there is a Tester Gel pump, which I don't like, or there's a sachets, which are a bit more of a faff, but they are just safer to titrate. And then there's Androfem, which is a private testosterone cream that is made in Western Australia. It's regulated, and the MHRA have agreed we can prescribe it, but it has to be done privately. Even as an NHS prescription, you can write a private prescription for it. So there is a choice. Some of you might have seen women on Testosterone pump or the Tester Gel pump, but we've seen women in the clinic who have very high levels of free androgen index, and some of them have had hair growth, and they've been using one pump every other day. And so you get these super physiological levels, and then you get nothing the next day. And I just don't feel comfortable when we've got an alternative to use those preparations. So certainly younger women and women who've had their ovaries removed, they really benefit from it. But actually most women do. It makes quite a difference, but the estrogen is the key ingredient, if you like, but the testosterone can make a huge difference. And I've already said it can improve mood, energy, stamina. And it doesn't take much to realize if a woman's mood, energy and stamina has improved, her libido will as well. So it helps with a lot. As I said, it's not licensed. So when you prescribe it, I've put this leaflet, a booklet that I've written, which is available to download from my website, because actually when you talk to women, they'll go, oh my goodness, no, I don't want a beard. So you need to give them information and give them time, let them think about it. But increasingly women have been hearing about testosterone, and you might have women actually coming to ask you. So they obviously need to have symptoms to be consistent with low testosterone. Like I say, these psychological symptoms, but muscle joint pains can be a sign of a symptom of low testosterone, and also poor sleep. Actually, sleep can really improve with testosterone. You have to make sure a woman's adequately estrogenized, and that's because testosterone just can convert to estrogen if you haven't got, or if a woman hasn't got adequate estrogen in her body. Baseline bloods are there's no real amazing guidelines. So we've sort of created our own in our clinic based on the available evidence, but we used to do baseline bloods all the time on everyone, and then lockdown came. But we actually did an audit of all our bloods, and every single woman who was perimenopausal or menopausal had low testosterone, low free androgen index. So it didn't change our management. So I sometimes offer it if women want to know what their baseline is, but it's not going to change my management. So you don't have to do a baseline testosterone or SHBG before starting testosterone. And then I usually say to women, explain how to use it, and then say, we'll just give it to you for 3 to 6 months and review how you feel. Because it's used as a cream or gel every day, they can stop it if they have any problems. But it does take a while. The estrogen can work quite quickly to improve symptoms, but the testosterone can take longer. So I usually say, if you don't feel better after 6 months, you're unlikely to, certainly, especially if they're absorbing it properly. So you can repeat the testosterone or do it for the first time if you haven't done a baseline. Testosterone and SHBG, you work out the ratio, times it by 100, and it gives you a percentage, which is their free androgen index. And I usually do it when I review them again. So depending on the clinical situation, between 3 and 6 months. There are some women who need to use slightly more if their level hasn't increased or it's still low. So if their FAI is still around 2 or below, then I would increase the testosterone before giving up. And then I would recommend just having their blood test done annually, just to ensure it's in the female range. So the 3 preparations we have are, like I've said, the Testogel, the Testim. So the Testogel and the Testim, you make 1 sachet or 1 tube, lasts between 7 and 10 days. Or the Androfem, it comes with a syringe, and it's 0.5 ml a day. So each tube, so the tube, I've got one here actually, is just a 50. It's a 50 ml tube, and it just lasts for 100 days. So it's expensive. It costs about £80 privately, and if women are being charged more, they're being fleeced. So with private prescriptions, pharmacists can charge what they like. So make sure they're not paying more than £80 for it. But if you break it down, that's 80p a day. Now, I don't eat chocolate, so my indulgence is testosterone, I suppose, because my brain works so much better with it. So it is still an option for a lot of people, actually. It does sound a lot, but it can make a huge difference. And I certainly would not be working if I wasn't using testosterone. My brain had gone to mush. So, but it's an individual choice, clearly. I wanted to just mention GSM as well. This lady's told you she's got symptoms related to vaginal dryness. Now, some of you might not be familiar with the term GSM. It's a bit of a mouthful, genitourinary syndrome of the menopause. And that was changed just to encompass the urinary symptoms rather than vaginal atrophy or vaginal dryness. And vaginal or vulvovaginal atrophy is a horrible term. If you look up atrophy in the dictionary, it's withering or wasting away. None of us want to think we're doing that. So it's actually a lot nicer, if you like, to have the GSM diagnosis. But this is incredibly common, and I have mismanaged so many women in the past. I didn't even think about it. I'm very embarrassed to admit to a live audience, but we are where we are, and I have seen so many women with recurrent UTIs in the past didn't even think about their dryness or their lack of estrogen in these tissues. So around 80% of women have these symptoms, and around 8% of women get treatment. So there's a lot of women in your practice that won't be getting any treatment out there. So as you know, it's due to the low estrogen in the vaginal and surrounding tissues. Symptoms include dryness, frequency, urgency, incontinence, and it progresses over time. Hot sweats and flushes might improve, but this progresses. So do you need examining if someone's talking to you? Well, actually, you don't. And I've discussed this with various gynecologists. This isn't just me saying no. Most of them just put for common things more common. They're more likely to be related to their low hormone levels. So safety net, if they've got some abnormal sounding vaginal bleeding, then I would definitely get them in to be examined. If they don't improve after a few weeks or even a few months, sort of after 3 months review, if they're not improving, they need examining. Or clearly, if the patient's worried, she's noticed a change, something's happened, or a partner's noticed something looks different, then clearly she needs to come in. There are different treatments available. We've got more choices than we have, which is good, but they're all really low dose and they're not the same as HRT. I put this slide on to show you how low. It's only 10 micrograms of Adjuvant. So if you look at this level, day -1 is placebo because it's obviously before having any. So that's the black line. Day 1, you'll see there's a little peak, but it's only 25 picomoles per litre. It's incredibly low. We see women who are obese with levels of 200-300 picomoles per mil. So you don't need to worry about that. And then it goes down. And actually, this slide shows you that day 82, the green line is lower than placebo, the black line. So it isn't absorbed systemically, which is really reassuring for women. And as actually, the more the epithelium, the vaginal epithelium is thicker because of having estrogen to stimulate the growth of those cells, the less it's going to be absorbed as well. So there's very few contraindications. If someone's got undiagnosed vaginal or uterine bleeding, obviously you wouldn't start it. I've said that. There's a theoretical risk of women taking aromatase inhibitors, but this is a theoretical risk. And actually, for these women who are really uncomfortable, who've tried non-hormonal preparations, I would still give vaginal estrogen too. Women who are on tamoxifen, women who've had breast cancer, women who've had estrogen receptor positive cancers can still use localized estrogen. There's no reason not to. And there have been some guidelines and some consensus statements saying these women need to be seen and reviewed by a breast team. But actually, a lot of these women we see have been diagnosed and they've been discharged from their breast clinic. So if you feel confident, then I would definitely carry on, use localized estrogen for women who've had breast cancer in the past. You just need to warn them about the information leaflet because it's very scary. It will talk about systemic HRT, but it will also mention clot, breast cancer. It's not relevant. You need to just warn them, otherwise they'll never use these preparations. And around 20% of women who take systemic HRT will still have some vaginal dryness. So they are allowed to use both. In your review, you need to ask about vaginal dryness. And if they need to use both, that's absolutely fine. There are these non-hormonal preparations. These are the better ones. And you can get samples or guide them to the websites and they can get some. Some of them more scented. The Durex preparations can cause a lot of irritation. So just be careful what they're using. Just want to mention antidepressants because we did a study of 3,000 women and found that 66% of women were offered or given antidepressants instead of HRT for the low mood associated with their menopause. There's no evidence for this use. They can be used for women who can't take HRT in the first line to help reduce the vasomotor symptoms, but they won't help low mood and they certainly won't help bone strength, heart function and brain function. So do not be giving antidepressants unless you've got good clinical reason to do so. Just going to go back to Amy before I finish. So you've diagnosed menopause. You're only 3 minutes into your consultation. This is going well. You will be home in time. You can explain her symptoms are likely to be related to her hormone deficiency. You can inform her there are real health risks of low hormones. You can ensure that she's up to date. You know she's missed one smear, but you can reassure her that she'll be feeling better soon and be able to have it. Look at breast screening. Now, she's only 48, but I've put this in as a prompt because we should be checking when people are in their 50s. We need to reiterate how safe HRT is. We can direct her to information, and this is on my website. I've written a huge number of booklets and fact sheets which are freely available to download. So she's keen on HRT. You're keen to prescribe it because you're very confident in it now. And then you think, oh no, should I have blood pressure done? Game over, I can't do it. What are you going to do? You just think, I was so close, and now what's happening? So let's just think, I'm just going to put this very quickly, this slide about heart disease and menopause. Coronary heart disease, cardiovascular disease is the commonest cause of death in women worldwide. Now remember that, more women die from heart disease than breast cancer. Most women with breast cancer die from heart disease. We can't ignore the effects of low hormones on our hearts. And the risk of heart disease increases, like I said. 30% of adult women have hypertension. And in low or middle income countries, it's more than half. So there's a heck of a lot of women who will be menopausal with raised blood pressure. and they've got increased risk of cardiovascular disease, are you going to deny them HRT? We know that every 20 millimeters of mercury systolic and 10 diastolic increase, there's a doubling of mortality from coronary heart disease and stroke. It's not really our place to ignore these women. So 26% of all deaths in the UK in women are from cardiovascular disease, and even borderline hypertension causes more problems in women than it does in men. So what about HRT and blood pressure? Well, transdermal estrogen can actually lower blood pressure. Micronized progesterone, I've already said, can be neutral or actually sometimes lower blood pressure. HRT can also lower cholesterol. So the NICE guidance do say, if a woman's got cardiovascular risk factors, address them, but you don't need to stop or withhold HRT. So it's not a contraindication, just taking HRT. So it doesn't really matter what Amy's blood pressure is, she can still have HRT. And if a woman hasn't had her blood pressure done recently, I usually say, try and have it done. And a lot of people, they've got one lying around at home, or they might be able to access one in a pharmacy or even buy one from Amazon. They're a lot cheaper than they used to be. And ideally, they should have an annual BP, just looking at their cardiovascular health. But it's not oral estrogen that you're using. It's not like the contraceptive pill. So you don't have to have a recent blood pressure. You can still start aiming on HRT. And this is very interesting. So HRT is actually, if you look at how the risk reduction is for primary prevention of coronary heart disease, then statins and antihypertensives are not as effective as HRT for reducing cardiovascular disease risk for primary prevention. The Cochrane data, and I'm not a statistician, but I wouldn't argue with Cochrane, they have shown that there's a 70% relative risk reduction of all-cause mortality, 52% relative risk reduction of coronary heart disease mortality, especially if women start HRT within 10 years of the menopause. That's really important to know. So for Amy, you're going to give her 100 microgram patch, change twice a week. Patches can be better for people with migraine. If you're a bit nervous, she can cut the patch in half and then increase after a few weeks. She's going to have a continuous preparation because it's been 18 months since her last period. You're also going to give her Vagifem because her symptoms are quite extreme. She might not need to continue it if her symptoms really improve with the systemic estrogen, but she can do, and it's quite safe to do both. You're going to suggest some non-hormonal preparations, and you're going to review her in 3 months' time. Then 3 months later, she's a lot better, but she's still got low libido, brain fog, poor sleep. So you're going to be brave, and you're going to give us some testosterone. You're going to give us some Testim available on the NHS. One box of 30 tubes will last nearly a year, so it's very cheap. You reassure her, you give her information, because otherwise she'll be worried because it's off license and it's for men. And then 9 months later, she's feeling amazing. She's applied for another job, she's got a new partner, her life's on track, and actually she's not been back to see any of your colleagues over this time. She's not wasted more GP appointments, she's had no more investigations, and actually her migraines have improved as well. So she is very happy, and you're really happy that you've transformed this woman's life in 10 minutes. So just finally, and I know I've run over, but I've tried to preempt a lot of questions. So women should receive individualized care. Menopause can lead to many different symptoms, but also health risks as well. And HRT really should be considered for most women, but especially younger women. We shouldn't be doling out antidepressants. We should be giving a lot more vaginal estrogen than we have done in the past. And we need to think about non-hormonal lubricants and moisturizers. And evidence-based information is key, and women are allowed a choice. We've got new consent guidelines that came out from the GMC last week, which are worth looking at. But even if women are aware of any risk, they have to be made aware of risks, but they have to be able to choose. So for those of you that want to know more, you're probably aware we've got this Confidence in the Menopause programme put together by myself and 3 of my colleagues with 14 Fish doing all the clever work, but we've got lots of cases to talk through. We've got lectures on there, and there's a community as well. So any of you can access that, and you'll get a certificate as well because you want to answer questions all correctly. But that can really help improve your confidence and knowledge, but also your practical prescribing. And then finally, for some of you who don't know, I've recently founded the Menopause charity because we really want to help as many disadvantaged women as possible globally who are really struggling. So lots to think about, and I hope that's been helpful. So thank you.
Louise, as always, that was absolutely amazing. For those of you who've not heard Louise speak before or seen any of her educational material, I hope that she's dispelled a series of myths that you've probably been dealing with. I do a lot of training in GP community, and a lot of young GPs are extremely anxious about any form of HRT prescribing and the risks. And, I can't blame them to a certain extent, because some of the information we've got from the MHRA is been quite frankly wrong. But there are over 400 people registered tonight, and we've already got well over 58 questions. So we're not going to answer them all. I'm actually going to start at the other end of the questions, just so that I think a lot of the early questions were answered by Louise as she went along. So I'll go to the end, and then, as I say, we'll perhaps give Louise 15 or 20 minutes of questions, and then I think she probably deserves a rest, really. But I'll take my camera off. Okay, and thank you ever so much for all those questions. We've now got on to 62 questions. So Lucy talks about, given the effects of progesterone that you mentioned on cognitive decline, is there ever an indication to give it even when not traditionally indicated, i.e. with a woman with no uterus?
Yeah, it's interesting. There's been a bit of work about the benefits of the micronized progesterone. Certainly, like I've already said, on bone health, it can help with sleep. But actually, the most benefit is with estrogen, and there is still a debate about the breast cancer risk. There's never been a good study that shows there is a convincingly increased risk of breast cancer in women with the natural progesterone. I have a few patients who've had a hysterectomy, and they were taking combined HRT before the hysterectomy, and they really like the sort of sedative effects. So for those women, they've taken progesterone, knowing that it probably has some benefits. But, when you think 10 to 20% of women have progesterone intolerance, I wouldn't just give it out to everyone. Some people think, well, you should give progesterone first because that lowers in the perimenopause before estrogen. But actually, there's not as good evidence for it helping our bones and our brain as well. I worry about osteoporosis. One of the reasons I take HRT, because I don't want to get osteoporosis. So the sooner to take HRT with estrogen, the better for our bone health. So, but it's about choice. It's about listening to your patient, working out what's best. So hopefully we can do more research going forwards, but menopause research is diabolical. So we might have to wait a little while.
So Claire Gray asks, could I ask about age and starting HRT in older women? And she says, thanks for a fabulous presentation.
Oh, thanks. Yes, so we see this a lot. So there are these lost decade of women because of the WHI study, which obviously I didn't go into tonight, but there's the most fantastic lecture that I have ever listened to by Professor James Simon on the Confidence Menopause course, unpicking all the evidence, worth listening to. But with older women, there are a lot of women who come who are in their 60s, 70s. We have one in our clinic who's 91 recently who wants to start HRT. What do you do? Because we know the biggest benefit is starting it within 10 years of the menopause, and these women are older. Well, actually, there is still bone protection. Even low doses of estrogen can help with bone protection, and it's a vasodilator. It can help reduce blood pressure, help lower cardiovascular disease risk. These women, I tend to start on a low dose, so give them usually the gel and say just start on 1 pump a day and gradually increase. There is a leaflet, fact sheet on my website for menopause for women starting slightly older or longer from when they stop their periods. But absolutely, there's very few people you can't give HRT to.
There's a few people on the question and answer section who haven't got a name there, so apologies for not saying who you are. But someone said, I assume that there's no tachyphylaxis in estrogen patches. I've got a 48-year-old who I started on a 50 patch, improved, but at 3 months got symptoms. So put up to 75 and again improved, and then got menopausal symptoms. They returned again mildly. So
Yeah, so it's
Continue
interesting.
going.
We were talking about this in the clinic recently, actually. So tachyphylaxis is something that traditionally has been seen with implants. I don't use implants because I don't see the reason, and actually it makes me feel a bit uncomfortable because people have to come back and see me privately, which I don't want. I want them to go back into the NHS. So a lot of it with using patches and gels is because you're not using enough. And someone like that lady, it'd be very useful to do her estradiol levels on, actually, because 75 micrograms is still quite a low dose for someone in their 40s or even their 50s. I would do their estradiol level. If it's less than 250, it will reassure you, it will reassure the patient as well that you can increase the dose. And she might need 100, but she might even need 200 as well. You know, I always say to women, estrogen doesn't build up in your body. So if you feel uncomfortable, you can just reduce it and you'll be back to where you are now. Nothing awful is going to happen, but it's also a lot of people find they feel amazing initially, and then after 3 months they feel worse again. They go, oh, the HRT is not working, doctor. It's because they're not on enough estrogen. And we're quite bold, and it works. So you learn from your patients, actually, but you're not going to get it wrong. Some women with hypothyroidism are on 200 micrograms of levothyroxine. You don't worry about those, and some women are only on 25. You know, you just go with the patient, but that's when blood tests can be useful sometimes.
There's quite a lot of questions about testosterone, Louise, and so could you go through the difference between Tostran, Testim, and Testagel?
Yeah, of course I can.
Use?
Yeah, so I mean, the number one thing is testosterone is very safe, and you know there is some good evidence about it, how safe it is. And we also know there's a bit of evidence it reduces amyloid deposition in the brain, potentially lowers risk of dementia. So that's enough for me to take it. But with testosterone, the three main ones to prescribe are Testogel and Testim. The Testogel is a sachet and the Testim is a little tube. Now they contain enough to last between 7 to 10 days. The tube of Testim is easier because you've just got a screw top, so they can put on a pea size onto their thigh, close the screw top and use it that way. The sachet is just a bit logistically more difficult. Use a paper clip, or some people decant it into a little Tupperware and then just use a pea size, making the sachet last around 7 to 10 days, rub it on their thigh. The androfen cream, which is this one, is a white cream rather than a gel. And I'll just show you on the screen, it's a white cream like this, and it's about that amount. It comes with a syringe and it's 1/2 ml a day, and the syringe is a pain to use. It is changing to a pump, actually. So women can just sort of guess, and the tube will last them 100 days. Again, they rub it on their thigh. The Tostran is a pump, and there is a Testogel pump, but it will squirt out twice the amount that you use. So some people will say, we'll use a pump every other day, so then it will average out. But I don't like that idea, because then you're getting a supraphysiological level and then nothing. And we have seen women, we saw someone recently who had a 300 index of 15, should be below 5, and it's just uncomfortable. You can get bioidentical testosterone, so compounded, not licensed, not regulated testosterone from various private clinics, which are never recommended at all. So I would only ever recommend something that's regulated. I'm hoping the license for the testosterone cream for androfen will come in time. There is a move to do it, but it's a massive, massive process getting something licensed.
So Laura says, I recently came across a 48-year-old woman who had a hysterectomy and removal of her ovaries, age 36, for ovarian cancer. She's asymptomatic and has not been on HRT. Do we wait till she's symptomatic, or should she have been on HRT a lot earlier?
Yes, there's two things in her. She's 36, so she's young, but also she's had ovarian cancer. Now, you need to just check the type of ovarian cancer, but most ovarian cancers are absolutely fine with HRT. When you look at the warnings, it will say risk of ovarian cancer. Now, this was an observational study, and it showed that there was an association, not a cause effect. And so we don't need to worry about risk of ovarian cancer. This lady has had her ovaries removed. It doesn't matter whether she has symptoms or not. She needs to have some replacement hormones because of the future risk to her health. And there's a great study by someone called Rocco, a Canadian professor, looking at the diseases associated with oophorectomy in women under the age of 40. And it's quite scary when you look at the slide of the diseases that increases. There's even diseases such as COPD, chronic renal failure, even psychosis, drug addiction. Every single system is affected because these women have accelerated aging without their estrogen. And, you know, so you really need to look. If you've got women who are under 45, who've had an oophorectomy, why aren't they taking HRT? Or if they're not got their periods and you think they're menopausal, they really have to have HRT unless there's a good reason for it because of their future health.
Louise, earlier you said about switching from cyclical to continuous after 6 to 12 months. And would you still do that in a younger woman, say in her early 40s?
Yeah, I would, Mark, because I know there's a lot of people when you read, I haven't even looked at the BNF recently, but they used to say 52, or or you've been on it if you're 2 years when you're younger. I don't know what happens to these women or what happens to their endometrium. My guess is nothing. It's just somebody's decided round a table. But you just think pragmatically, you know, most women don't want periods. They're a real nuisance. So the sooner we can get rid of them, the better. But I'm saying that, but there are some women in their 20s and 30s, they do want periods because they want to be like their friends. And actually, I mean, it's safer taking the HRT rather than the oral contraceptive pill because of the health benefits that have got more evidence and because of the natural way that we prescribe HRT. But those women might want to carry on having periods. So it's quite safe to just go with a patient. If she wants periods, carry on with cyclical. If she doesn't, and a lot of these women have really struggled to conceive, the periods are just a reminder of their reduced fertility. They might say, look, I really want to stop them. So then they can go on to continuous. So there isn't an age at all for changing. It's more the length of time that they've been since before having their periods. So if they're still having periods, start them on cyclical for 6 to 12 months. If they are within a year of their last period, then again start. So this lady, Amy, was 48, but she'd been 18 months since her last period, so she can go straight on continuous.
There's quite a lot of questions, and I first heard you talk over a year ago now, and so completely changed my practice. In particular, prescribing a lot of micronized progesterone, which caused chaos with my local chemist, and it comes up as an amber warning. So there's a couple of people who are saying, you know, showing the anxiety that I had. I now use more utrogestone in the south of England than anyone else. But just really just a few comments of reassurance about someone from Birmingham has said that, you know, it's not the first line progesterone. What should she use? I mean, I would encourage her to use it.
Yeah, so I was a GP in Birmingham, and I don't even want to start telling you the battles that I've had, because it's actually a RICAD, and they actually saying you can only prescribe it if a woman is intolerant of MPA or norethistrodone, if they refuse a Mirena, if they've got a family history of breast cancer, and those indications don't make sense. There's no evidence behind that. That makes no sense at all, but they won't push back on it. And actually, doctors, we're independent prescribers, and we have to prescribe according to the evidence. Now, there's really good evidence, and if any of you go on the Confidence Menopause course, I've put as much evidence as I can with every single case, with every single lecture, so you can read and go and have a look. But the evidence for the breast cancer risk should be enough to make you prescribe micronized progesterone. But if that's not enough, look at the cardiovascular risk and the VTE risk of the synthetic progestogens. And that's got to make a big difference. So I think you need to push back and say, actually, you know, we've got a better alternative. It costs the NHS about £4 a month to prescribe micronized progesterone. It's very cheap. So, you know, just because it's there and it's on amber, you're not going to be taken to court because you prescribe something that's safer for your patient.
No, absolutely. And it's interesting that some of the people that, even the women's health doctors in my practice who gave me a hard time to start with are now coming over. So that's absolutely great. Well, it's 8:30, and we're definitely planning to do more of these. You know, if you're interested in seeing the Confidence in the Menopause package, please go to 14fish.com. I'm sure you'd all want me to thank Louise. There's been massive amounts of positive comments in the chat. And so I hope you all have a a very good evening. Once again, thank you, Louise. Thanks for the 14 Fish support team for putting this on. And we're going to try different things. So let us know. Do give us some feedback of the sort of things that you want. And we hope you have a good evening and enjoy the rest of the week.
Thanks, everyone.
Bye now.